We have about 35 people on the call, so thank you so much, everybody, for being here. Hello, my name is Andrea Estrada, and I will be facilitating the webinar today. I'd like to welcome you on behalf of UC San Diego's Parkinson and Other Movement Disorders Center to our Parkinson's Disease 101 webinar. Each month, we have a virtual session on different topics related to Parkinsonism and living well. Our hope is that you will learn something new and find this information relevant and useful in your day-to-day lives. Today, we will be focusing on Parkinson's disease, giving you an overview and management options. Dr. Caitlin Mulligan and Dr. Robert Hess will talk about treatment management, outlining options and recommendations, including insights on ways to improve the quality of life for people with Parkinson's disease. A few things to note. This is the third of 6 educational presentations that our center will hold this year. Sessions will be recorded and available online at movementdisorders.ucsd.edu. And this website is also where you will find upcoming session details, so you can register for more upcoming sessions. Any links or resources shared during this presentation will be emailed to you. We will also send a post-session survey for you to complete at your convenience. They're really helpful for us for future events. And lastly, there will be time at the end for questions. Thank you. Now I'd like to welcome Dr. Hess.
Hello, good morning. Let me share my screen. All right, so hello, my name, like Andrea said, is Dr. Robert Hess. I am the new attending physician joining the UCSD Movement Disorders family this year. I know I have met many of you over my years training here, and I am excited to continue my career here at UCSD. I have been tasked today to give a brief overview of Parkinson's disease. This is by no means all-encompassing and will be just kind of the broad brushstrokes of the disease. Before I get started, I want to say thank you again for this opportunity to be here with you all. I'm looking forward to learning more about your own experiences with Parkinson's disease and how we can work together to improve life with this disease. As Andrea said, my objective today is an overview of Parkinson's disease. So we will cover kind of the history, the epidemiology, or kind of the incidence and prevalence of the disease, some clinical features or symptoms that can happen in the disease, as well as kind of some theories and mechanisms of how the disease occurs. And of note, we will just focus on the idiopathic Parkinson's disease, or kind of the one that everyone is most familiar with. Before, like I have on my slide here, I was a history major in my undergraduate studies, so I'd be remiss to skip an opportunity for a brief history lesson. So going way back in time to the 3rd century BCE, there's an Indian scholar named Charaka who actually described motor and non-motor features of Parkinson's disease that we know of today, including tremor, slowness, gait imbalance, and even depression as well. They named the disease Kampavada, which from the ancient Sanskrit was the names for tremor, Kampa, and the spiritual force of Vata, which was out of balance in the disease. And amazingly, they actually had some treatments that included several plants and seeds, including Atmagupta, which was Mucuna pruriens, which is known to have 4 to 6% of a dopamine substrate within it. However, we still do not recommend this as a good substitute for levodopa in the modern day times, but I thought it was an interesting fun fact. Jumping forward almost 2,000 years, we get to 1817 with an essay of the shaking palsy by James Parkinson, which kind of led us down this road to how we know Parkinson's disease today. He did a lot of clinical observations of 6 cases he saw, some just on the streets of London as well. Moving forward in 1872, there is Jean-Martin Charcot, further defines the disease and gives a lot more descriptions to the Parkinson's disease we know today, including giving two different symptom models, the tremor and bradykinesia, or slow movement. He even suggested the name Parkinson's disease. And importantly, he recognized that Parkinson's disease does not have a motorically weak syndrome, that there is no change in the power that the muscles can produce. He finally noted a difference between action and rest tremors, kind of tremors that we do when we're using our hands or using our feet, grabbing a cup of coffee, or a rest tremor sitting there watching TV. And he noticed several accompanying symptoms with an action or a rest tremor as well. And I promised last slide for history, moving quickly, 1895, Richer and Mage provided detailed drawings of statues of patients with Parkinson's disease. Brissaud proposed that substantia nigra in the midbrain be the anatomical seat of Parkinson's disease. We didn't get into that further, and I know that might be a little too detailed, but helped us further along our understanding of Parkinson's disease. And finally, you see in 1953 and 1967 further findings as we go along. There's obviously been a lot more discovery since then, but I want to do a brief history on kind of our foundation of Parkinson's disease. Moving on to epidemiology, Parkinson's disease is the second most common neurodegenerative disease in the United States after Alzheimer's. Prevalence-wise, it is about 0.5 to 1% in ages 65 to 69, and 1 to 3% in ages 80 and higher. So as our population is aging, you can see that our prevalence has been increasing. Currently, about 1 million people are living in the US with Parkinson's disease, and that's expected to rise to 1.2 by 2030. And helping contribute to that is about 90,000 people are actually diagnosed every year with Parkinson's disease. We'll get into a little bit of the risk factors and some of the potential causes of Parkinson's disease, but age remains the strongest factor in terms of risk factor for Parkinson's. So a definition to kind of hang your hat on. It's a progressive neurodegenerative disease characterized by tremor, rigidity, bradykinesia, and postural instability. So as we've come to know this disease, it is much more than just these 4 symptoms. So we'll kind of break down and see what other symptoms can happen in Parkinson's disease. This is a general diagnostic criteria that we use to help diagnose Parkinson's disease. Again, this is by no means all-inclusive, and it is constantly in flux with new research and new testing, such as the DAT scan, alpha-synuclein testing. But this is a way that we kind of put Parkinson's disease in our mind in terms of bradykinesia, plus one of the following, the tremor, rigidity, or postural instability, and absence of other symptoms that might put us into a different disease category away from idiopathic Parkinson's disease, or the one that is most well known. I like this graph as giving an idea of kind of the progression of the disease and different symptoms that can occur as the disease goes forward. This is just one proposed theory. This is again constantly in flux, but helps give a baseline or a kind of a bracket in order to picture the disease as the neurons in the substantia nigra start to fade away. Different symptoms start to occur, including motor and non-motor symptoms, which we'll get into in just a little bit. Such as now. So here's our clinical features and or otherwise known as symptoms. First are the motor symptoms, which most people are aware of. The tremor, which is kind of the most prominent and most easily recognizable. Most commonly is asymmetric, or will affect the right side or the left side of the body. More commonly in the upper extremities versus the lower, so very commonly in the hands first. Bradykinesia, Latin for slow movement. Rigidity, kind of that stiffness of the arms as moving through the motions. And then postural instability, with freezing of gait, a shuffling gait, something we call festinating steps, or those kind of very small, quick steps as you're walking, and very slow turns, or kind of taking many steps to make a 180-degree turn. And there's a lot of non-motor symptoms that don't have to do with movement that we've become to know with Parkinson's disease as well. This is, again, by no means all-encompassing, but just kind of the highlight of some of the more important ones that we've become to know. One big one is something called REM sleep behavior disorder, or for short, RBD. This is the acting out one's dreams or thrashing about while sleeping. Of note, sleepwalking is not the same as this, and it is a very specific symptom in predicting future Parkinson's disease diagnosis. So it's something we ask about all the time, and we do have treatments available for it as well, but it is highly tied with Parkinson's disease. Constipation, extremely common in and out of Parkinson's disease. There are many dietary and pharmacologic treatments that we can help with this, but it is extremely common. There was a study looking at how common it is prior to even the diagnosis of Parkinson's disease, that even up to 10 years before diagnosis, patients who will eventually develop Parkinson's disease have a 2 times risk of having constipation compared to the general population. Urinary symptoms, frequency, urgency, again, very common, can be up to 2 times risk as well in developing future Parkinson's disease. Mood disturbances, very common, depression and anxiety. This can be chemically related to the patient's underlying Parkinson's disease diagnosis, and not just be situational or something that's going on in life, but can be part of the disease. So I think that was important to know that there is something we can do about it and is related to the disease. Moving on to kind of later stages of the disease, there's autonomic dysfunction, which means there's things that can kind of start fluctuating, such as blood pressures, urinary symptoms, and skin changes can occur. Again, these are things that can occur. They don't mean that they will occur, but just some symptoms and signs that we see every day and we treat. Hallucinations as well. These can be visual in nature. They can vary from a sense of a presence next to you or behind you to all the way to fully formed people and animals. This can be disease related or even medication related. It's very important to disclose this to your physician or to the treatment team, as well as we can work together to reduce these and keep everyone safe as well. Now, more importantly, swallowing difficulties can occur. We do speech therapy and diagnostic studies to help assess this and come up with a great plan to keep you as safe as possible, to make sure swallowing well. And finally, falls is one of the most important events that we try to prevent. Can be related to all the motor symptoms we discussed before, or even improper assistive devices. What I have shown here is a U-step walker. It's the walker that we highly recommend in Parkinson's disease. It is much heavier than the standard walker, but it makes it more difficult to fall backwards, which is a big problem in Parkinson's disease as well. Then, of course, physical therapy and exercise are paramount. So how does Parkinson's disease work? There's many theories, and this is still ongoing research in terms of the etiology of Parkinson's disease. One of the main mechanisms of the disease is this protein alpha-synuclein that misfolds and then starts to aggregate inside the neurons and then causes dysfunction in the mechanics of the neuron. And then there's these other proposed mechanisms, unsure if it's a primary factor or a secondary factor in terms of the process of the disease. But these are other areas under active research that we're looking into and could be potential targets for therapies in the future as well. Like I mentioned, this is the alpha-synuclein protein that starts to misfold and then start to gunk up the machinery of the neuron, which eventually leads to the neuronal death. And these neurons are the ones that produce dopamine, so it leads to a lower dopamine level in that important part of the brain. This is a very complex flowchart, by no means needs to be memorized, but just wanted to highlight how the substantia nigra is very important in this process called the basal ganglia, which controls the coordination and speed of movement. and then how decreasing that dopamine in the substantia nigra can lead to the symptoms that we see in Parkinson's disease. This is a model of disease progression. This is, again, a theory that was proposed many years ago, but I thought it was a nice way to kind of have an idea of how Parkinson's disease spreads, how it can start in certain areas of the brain and kind of spread, and then it highlights different symptoms that we see pop up in the disease as well. So the big question that is still being looked at is, why does Parkinson's disease occur? The vast majority of cases, we cannot point to a singular cause, and that's what we call idiopathic disease. Current theories include a combination of environmental and genetic factors that contribute to the disease development. However, those of you who know Parkinson's disease patients or are one of our patients as well, no one is the same, and that Parkinson's disease presents very differently from patient to patient. So it's a very heterogeneous disease, and it's making it very hard to come up with kind of the cause for what causes Parkinson's. Briefly, I'll touch just a little bit on genetics. About 10% of patients report a family history of Parkinson's disease. Only about 3 to 5 of those patients can show one gene that they can point to that can contribute to Parkinson's, and there's many more that are risk factors. There's a list of just a few that are the most common, which we sometimes test for if we do find a family history of Parkinson's disease, but by no means is this encompassing as well. So that was very quick, brief overview, kind of the broad brushstrokes of the disease. There's many things that are coming up in research, and happy to answer more questions. I wanted to keep it as broad as possible, and then we can dive further in. But yeah, that's where I will leave it for now. Thank you very much for your attention.
Thank you so much, Dr. Hess. Dr. Mulligan?
Yeah, let me get my slides up here. Thank you, Dr. Hess.
Of course.
And let's get my slides up here. Okay, so hopefully you can all see that. And so I just wanted to introduce myself first. My name is Caitlin Mulligan. I am an assistant clinical professor here at UCSD. I have been here for about 4 years now, and it's exciting for everybody to be here, and I'm thankful for the time that you guys are deciding to spend here learning a little bit about Parkinson's. So my topic for today is really about the kind of treatment options for motor symptoms of Parkinson's. Following up on Dr. Hess's talk, where we just learned kind of a broad overview about what Parkinson's disease is and what are some of the symptoms of Parkinson's. Now we're going to take a moment and talk about how can we manage some of these symptoms. So some of the things we're going to talk about today are defining the motor symptoms of Parkinson's. What are the medication options? Some of the non-medication options, when to start medications, and then a summary slide and time for questions. It's a kind of a lot to cover in a short period of time. So forgive me if I'm talking quickly. So as Dr. Hess just said, Parkinson's disease is a complex disease that involves both symptoms of the motor symptoms as well as non-motor symptoms, and these can both impact functioning significantly. So some of the motor symptoms of Parkinson's are slowness of movement, or what we call bradykinesia. And this typically affects coordination. As Dr. Hess pointed out, it doesn't usually cause weakness, but it can still impact coordination because of this symptom, slowness of movement. Then there's stiffness in muscles, which we call rigidity. There's tremor, which is usually a tremor that occurs at rest, though it can also occur while using your hands. It can cause changes in walking, balance, speech, swallow function. And these are all some of the motor symptoms of Parkinson's. Now, in terms of non-motor symptoms, Parkinson's can affect sleep, mood, depression, and anxiety are extremely common in Parkinson's disease. It can cause changes with blood pressure control, which is that autonomic dysfunction Dr. Hess was mentioning. Bladder control, constipation also kind of falling under that autonomic dysfunction. Drooling, cognition, meaning changes in thinking and memory, and then also pain. So really the focus of this talk today is going to be the treatment of motor symptoms. And there are treatments for a lot of these non-motor symptoms, but I think this is where I want to focus today's talk is what can we do to manage the motor symptoms of Parkinson's? So here is kind of a slide summarizing some of the different kind of categories of medications for Parkinson's disease. Now, we're going to go through each of these and talk about all the different drugs in each of these kind of categories. But the way I think about it is there's levodopa, which we will talk about. There is a category of drugs called dopamine agonists. There are a category of drugs called dopamine enhancers, and then there's drugs for tremor or other specific symptoms. And so if we look at this figure here, this is kind of a summary slide that we'll come back to when we're talking about these different categories. Dr. Hess was just mentioning that the substantia nigra in the brain degenerates in Parkinson's disease, and those neurons will actually send neurons to something called the striatum. And this is a picture of these neurons that are coming from the substantia nigra and releasing dopamine into the striatum. And if these neurons degenerate, essentially there is a lack of dopamine in the brain. And so we have different ways of helping with this. One of the main ways that we help with this is levodopa, right here, levodopa, this L, which is kind of a prodrug, and it essentially helps the brain make more dopamine. And that is important because in Parkinson's disease, there's a deficiency of dopamine in the brain, and that causes these motor symptoms of Parkinson's that we've been discussing. So when levodopa is given, more dopamine is made, and that allows for more dopamine to bind on what we call the postsynaptic neuron in the striatum. There's other things that we can do to help boost dopamine in the brain. Dopamine agonists, right here, DA, dopamine agonists, are medications that bind to the receptor and kind of trick the brain into thinking that dopamine is present, even though dopamine may not be present. And then there's ways that we can enhance dopamine. And essentially, if we decrease the breakdown of dopamine, we can do that in different places with the MAOB inhibitors or the COMT inhibitors. These help decrease the breakdown of dopamine, and it preserves kind of the duration that dopamine is present and can overall boost dopamine. So let's go through these one by one. So we're going to start with levodopa. And as I was mentioning, levodopa works by the brain taking it up and making it into dopamine. And so it supplements deficient dopamine. In general, I think of levodopa as an oldie but a goodie in terms of medications. This is our most effective medication to relieve motor symptoms of Parkinson's disease. It is also one of our oldest medications, but it is a good one. Now, of course, every medication comes with possible side effects, so I'm going to review some of those side effects with you today. In terms of levodopa, one of the most common things that people experience when they're taking this medication is nausea or upset stomach. Now, practically all preparations of levodopa come with a built-in medication to mitigate this side effect of nausea. So that's the purpose of carbidopa. So usually when you're on your medication, you'll be prescribed carbidopa/levodopa. The levodopa is what is taken up by the brain, and the carbidopa is there specifically to help with the side effect, especially nausea. So nausea is one of the most common things. Carbidopa helps mitigate that. There's other tips. If you experience nausea when you're taking this medication, talk to your doctor about it, because there's other things that we can do to help with this side effect of nausea. Some other possible side effects with levodopa is low blood pressure, especially when going from sitting to standing. This is the what we call orthostatic hypotension or autonomic dysfunction that happens in Parkinson's. Now, we just mentioned that this could happen just from Parkinson's disease itself, that you could get a problem with regulating your blood pressure, but medications play a big role in that problem as well. And unfortunately, levodopa is one of those medications that can worsen orthostatic hypotension or low blood pressure upon standing up. Other possible side effects, hallucinations. And Dr. Hess just described so how these can kind of be mild, maybe just a sense of shadows or feeling that someone is next to you, or they can be more detailed. And there's a big range of hallucinations. Dyskinesia is something we're going to talk about more later on. Dyskinesia is an excessive involuntary movement that sometimes appears as a rocking or swaying movement. It's different than tremor. Tremor is a very rhythmic movement. Dyskinesia tends to be more random or dance-like. This can be a side effect of levodopa, and we're going to talk a little bit later about some of the concerns about dyskinesia and how we mitigate it. So moving on to the different formulations of levodopa. This is a busy slide, but I'm hoping that you can appreciate that there's lots of different forms of this medication. And I think one of the reasons for that is because it is such an effective medication. However, there are side effects, as we just covered, and the different preparations are really geared towards mitigating some of those side effects in different ways, or have a different preparation to help with specific problems. So let me talk a little bit more about that. So I would say the most common preparation is carbidopa/levodopa. This is the immediate release form. These are most likely these yellow pills that many of you are familiar with. They do come in larger doses. So there's a blue pill as well. I have one patient who calls it his blue bomber because they're higher dose medication in one pill. But most times we're using these yellow pills. And then there's a controlled release form that looks a little bit like this. Sometimes it looks a little bluish or grayish. And with this, it's absorbed a little slower from the GI system. And it's a little bit slower to be absorbed and doesn't have as much of a big peak as the immediate release Sinemet. That can be desirable for some people, especially for nausea purposes, might be a reason why we would use the Sinemet controlled release because the peak dose is where usually patients are getting nausea. Rytary is one of our newer forms of levodopa. This is a capsule, and the capsule, inside the capsule, there are beads, and the beads have different coatings. The coatings degrade at different rates. And so essentially it's like a little bit of immediate release, a little medium release, and a little controlled release all in one pill. This can be a very effective therapy for people with dyskinesias or off times. And it can also be helpful to mitigate some of the peak dose side effects that people have. The problem with Rytary is that it can be expensive on certain insurances. And so that's one of the reasons that we try to maximize our kind of standard medications, but Rytary is a good option for certain patients. There's also an oral disintegrating form of levodopa that's called Parkopa, and this can be helpful for people who have difficulty with chewing or swallowing, especially when their medication is off. Similarly, inhaled formulations, there's Inbrija is an inhaled form of levodopa. This can be helpful for people when they need a very quick hit of levodopa, to get a sudden drop off in the levodopa, giving them off time. Then Inbrija sometimes can be helpful for that. There's also more advanced therapies like Duopa. Duopa is an intestinal gel of levodopa. It requires the placement of a tube into the small intestine. So it goes through the stomach into the small intestine. And then there's a pump that gives you continuous administration of this gel that contains levodopa. This is what we would consider an advanced therapy. And it is helpful for people who have those motor fluctuations, those big ups and downs of the day, which are typically, dyskinesia is part of that up and down of the day. And it can be helpful for that problem. It's obviously quite an invasive thing. And so it's not our first thing that we go to. In terms of future formulations, actually there's several things that are being studied. There's a kind of like a new type of Rytary that is being reviewed by the FDA. There's a subcutaneous pump of levodopa that's under study as well. And so even though we have lots of preparations of levodopa, there's lots of interest in even making further advancements in the preparations of levodopa to help, because this is such an effective therapy to reduce motor symptoms of Parkinson's. Okay, moving on to our next category. Now we have dopamine agonists. And as I was mentioning, dopamine agonists trick the brain into thinking that dopamine is there, even if it may not be there. And so it acts on this green part, this receptor, and it stimulates this dopamine receptor. Now, this is a medication that results in mild improvement in motor symptoms and functioning. But of course, side effects are always on our mind. Potential side effects with dopamine agonists would be daytime sleepiness. In severe situations, this can even mean sleep attacks. It can also cause blood pressure control problems, orthostatic hypotension. This seems to be a little bit more of a problem with the dopamine agonist compared to levodopa. And one of the things we are more aware of now compared to when these medications came out was something called impulse control disorders. So we now know that people who have been on dopamine agonists for a long term and at higher doses are at higher risk of developing problems controlling impulses. And so that might mean problems with controlling gambling, hypersexuality, compulsive eating. All of these things can be related to the dopamine agonist medications. Hallucinations are actually more common in dopamine agonists than levodopa. And then some people can get some swelling in their legs, something that we call edema. So in terms of different brands and formulations of dopamine agonists, ropinirole and pramipexole are the ones that are most commonly used, probably. They come in both immediate release and extended release forms. Brand names would be Requip and Mirapex. There's also a patch form. This is called the Nupro patch. And the Nupro patch is a nice option. It actually does minimize some of the side effects we just discussed. So the patch is less likely to cause some of the side effects. And then another rescue medication is something called apomorphine. This comes in a pen that allows you to give an injection. This is also used for those sudden off times when all of a sudden the medication is off and you need a quick acting medication to help you get going again. Sometimes the Apokyn or apomorphine pen is used. Okay, so our next category of medications, dopamine enhancers. So really, if we're looking at this figure, we're talking about something called the COMT inhibitors and the MAOB inhibitors. Now, COMT and MAOB are the enzymes that break down dopamine. And by inhibiting them, we can decrease the breakdown of dopamine and make dopamine last longer. Also in this category, I put a newer medication that's not in this figure, but that a new medication that works on the adenosine receptor and essentially results in boosting dopamine signaling. Now, these dopamine enhancers have a mild benefit in reducing motor symptoms and off time. They're mostly used as an add-on to levodopa, so in conjunction with levodopa, with the exception of some MAOB inhibitors that are used in some cases as an initial medication therapy for patients with mild symptoms. In terms of side effects, I would say generally these medications tend to be pretty well tolerated. Again, they're more mild in terms of the benefits of motor symptoms, but they tend to be pretty well tolerated. Most of the effects are usually related to the boost in the dopamine in the brain. So you can increase hallucinations or dyskinesias, et cetera. In addition, MAOB inhibitors carry a rare risk of medication interactions with certain medications that are given at the same time. Here are some of the formulations of the dopamine enhancer medications. The MAOB inhibitors are medications like selegiline, rasagiline, safinamide. Safinamide, Xadago, is the newest medication in this category that was released in the past 5 years or so. And COMT inhibitors, tolcapone is the oldest medication, and tacapone has been around for a long time, as well as there's a formulation of entacapone with carbidopa levodopa called Stalevo So you can kind of get entacapone with the carbidopa, levodopa all in one pill, which can be convenient for some patients. And then the newest medication in this category is called opicapone or Ongentys. And then this last category is the adenosine antagonist. I mentioned it's not on that figure that we've been talking about. It's the only medication that really works on the adenosine receptor. It's called Norians, or I'm going to have a hard time pronouncing this as well, estradifylline. And so Norians is one of the newer medications that can kind of boost levodopa. Okay, and then our last category here are drugs for specific symptoms. So for tremor or dystonia, medications that block acetylcholine may be used. And this is different than the dopamine pathway in the brain. In reality, it's not as simple as we just painted it out to be as being a deficiency of dopamine. We know that there's other chemical changes in the brain that happen in Parkinson's disease. And so specifically for tremor, we know acetylcholine is involved in that. And so if we block acetylcholine, then sometimes we can help with tremor and dystonia. So there's two main medications, trihexyphenidyl and benztropine, also called Artane for trihexyphenidyl, and the brand name is Cogentin for benztropine. The side effects of these medications are significant: confusion, hallucinations, constipation, difficulty emptying the bladder, or urinary retention. And essentially, these are not well tolerated in older individuals. And that's one of the reasons we don't use them commonly in Parkinson's disease. We may use them in younger patients who have predominant tremor or dystonia, in addition to the dopaminergic medications. Okay, let's talk about dyskinesia. So this is another specific symptom. There's really, for dyskinesia, oftentimes we talked about how levodopa is involved in dyskinesia. However, we do have some medications that we can add to help reduce dyskinesia. And these are medications that block glutamate. Now, mainly these are formulations of amantadine. Amantadine is a medication that's been around since the 70s. It was actually made as an anti-flu drug. And then it has, when it was given to patients with Parkinson's, there was some improvement in the Parkinson's symptoms. Now, more recently, there's been an extended release, two different extended release forms that have been approved, Gocovri and Osmolex. And these may be helpful to mitigate some of the side effects with amantadine. The typical side effects would be blood pressure control problems or orthostatic hypotension that we've been talking a lot about, as well as confusion and hallucinations. So this medication, amantadine, and its other extended release formulations, we're usually only using as an add-on to levodopa when dyskinesias are present. Now, I wanted to talk about non-medication therapies. And really, the rehab part of Parkinson's is a huge part of therapy for Parkinson's. I really consider this should be a prescription from your doctor to do exercise as part of your Parkinson's treatment, because it's an evidence-based way to reduce motor symptoms for Parkinson's disease. And so exercise can come in lots of different forms: aerobic exercise, strength training, balance, agility, multitasking, strength training, and stretching. And here, this is something from the Parkinson's Foundation, really kind of mapping out how much you should do of each kind of exercise. But it's a really important non-medication way of improving motor symptoms of Parkinson's disease. There's also additional evidence that exercise may be neuroprotective for Parkinson's, and we do not have other medications, prescription medications, that are neuroprotective for Parkinson's. And so exercise is one of those things that can help you actually do better in the long run for Parkinson's, and is a really important part of Parkinson's treatment. There's also other important therapies. Speech therapy can really help with some of the voice symptoms of Parkinson's and swallowing. Occupational therapy, they are really great at thinking about what are the problems you're having in your day-to-day life and what are ways we can fix them. And these are non-medication ways. So things like using different types of utensils or using a shoehorn, or things that can really help you maintain function and independence. Okay, moving on to other non-medication therapies, surgery. I'm not going to have a ton of time to talk about surgery, but really there's surgical options are really for two different problems in Parkinson's. One is for tremor that happens despite best medication management. So people who have tremor that impairs function despite being on medications may be a candidate for a surgical option. And then also motor fluctuations. These are those ups and downs of the day marked by on time. Typically dyskinesia would be present, and then off time when people are not functioning well because levodopa is not working. So two procedures I'm going to talk about: deep brain stimulation and focused ultrasound. Deep brain stimulation is a surgery. It requires placement of electrodes into the brain, and there's two different parts of the brain that we may send electrodes to, and then the placement of a battery pack and a wire under the skin that connects to those electrodes. Deep brain stimulation allows both sides of the brain to have the therapy, and we can also increase or decrease stimulation depending on how much benefit you're getting or if you're getting side effects. Now, that's in comparison to focused ultrasound, which is a procedure, so it does not require cutting the skin, and it's done under MRI guidance, and it uses ultrasound waves to heat up and damage a part of the brain. Now, this is in this procedure, only one side of the brain can be done, which is a major downside for Parkinson's because Parkinson's affects both sides of the brain. In addition, this is something we call a fixed lesion. So whatever benefits you get of the surgery or what you get, you can't turn it up or down, and whatever side effects you can't turn it up or down. Okay, so I think I'm running out of time here, so I'm going to start going faster here. But when should medications be started for Parkinson's? Really, exercise should be at all stages. And otherwise, it may be appropriate in the beginning to monitor symptoms if they're not impacting everyday functioning. But if motor symptoms are impacting function, then medications should be considered. Now, here are some questions you might ask yourself to really figure out, are my symptoms affecting functioning? Does it take longer to do everyday tasks like eating, dressing, bathing? Are you avoiding activities because of stiffness, slowness, tremor, walking problems, etc.? Are other people helping with things that you could previously do independently? Or are you considering giving up work or hobbies because of the symptoms? Are you avoiding social activities because of this? All of these may be reasons to start medication. From my perspective, it's much better to take medications and maintain independence and maintain all of these functions than to give up these functions. So what is the best initial medication? For mild symptoms, as I mentioned, mild medications like MAO-B inhibitors may be appropriate for initial therapy. One of the benefits there is that these medications tend to be once per day medications. And so the levodopa is a 3 times per day medication, which is a bigger change in terms of your routine and how you have to take medications and remember to take medications. But for symptoms that are causing more advanced disability, levodopa is usually preferred. I did want to spend a few minutes talking about levodopa phobia because this is something that I get asked about very frequently. Essentially, there was a time when dopamine agonists were started as a first line in Parkinson's because of some concerns that levodopa causes dyskinesia. And I wanted to say that we really know a little bit more now about dyskinesia, and we also know more about dopamine agonists. Dopamine agonists, we know now, do not relieve motor symptoms as well as dyskinesia. And so there is more remaining disability with dopamine agonists compared to levodopa. In addition, dopamine agonists do not delay the onset of dyskinesia. So when patients who were taking dopamine agonists eventually switch to levodopa, they still get dyskinesia. And it is more likely related to the brain changing over time rather than early exposure to levodopa that causes dyskinesia. Also, dopamine agonists have more side effects, especially the impulse control disorder, something that we really worry about. Daytime sleepiness, hallucinations, we talked about as well. So my question, so the way I view it in terms of levodopa versus dopamine agonists, now, why would we be giving you a medication that does not relieve your disability as well? It does not delay the onset of dyskinesias, and it has a higher side effect profile. And so essentially there's, I think, levodopa is really probably the mainstay of therapy. We also have new, better advanced tools to help with the problem of dyskinesia if that does occur. So Rytari I mentioned, Duopa I mentioned, deep brain stimulation I mentioned, and amantadine I mentioned as well. So after that whirlwind tour of treatment for Parkinson's, this is the summary slide. Parkinson's motor symptoms, bradykinesia, rigidity, tremor can be treated initially with levodopa, dopamine agonists, MAO-B inhibitors, or if it's tremor only, we might use an anticholinergic medication. Then we may add on therapies for wearing off, the MAO-B inhibitors, the COMT inhibitors, Norians, or amantadine is added for the dyskinesia. And in advanced therapies, we may be using the Duopa, which is the intestinal suspension gel, or deep brain stimulation, or focused ultrasound has limited use in Parkinson's. And at all times, really, the rehabs should be used in conjunction with the medications for Parkinson's. That is me talking over my time. And now I think we're moving on to questions.